Welcome back to the Deep Dive. Today, we are opening a file that I think a lot of people would probably prefer to keep closed, mostly out of, fear or maybe just a total lack of awareness. We are tackling something that is, I think, arguably one of the biggest silent problems in modern medicine.
It really is. We are looking at a massive stack of research today, all centered around the clinical management of chronic kidney disease.
Right.
And while that title might sound a bit dry, like something you'd just gloss over in a medical journal, the stakes underneath it are, they're absolutely massive.
Massive is definitely the right word.
Yeah.
I was reading through the source material, and the numbers just jump off the page. We are not talking about some rare condition here.
Not at all.
We are talking about chronic kidney disease, or CKD. And according to the data, this affects more than 697 million individuals worldwide.
Just pause on that for a second. 697 million.
It's hard to even picture.
It is. It's a number so big, it is almost hard to visualize. That is nearly 10% of the entire global population.
Wow.
To put it another way, that's roughly twice the population of the United States, just dealing with this one condition.
It's staggering.
Yeah.
And the human cost, that's just as high. In 2017 alone, the sources note that CKD resulted in 1.2 million deaths.
Yeah.
But there was this other metric that really caught my eye, and I want you to explain it because it sounds so important. They mentioned disability-adjusted life years, and it clocked in at 35.8 million.
Right. And this is such a crucial concept in public health. Disability-adjusted life years, or DALYs, is a way that experts measure the true burden of a disease. It's not just counting how many people died.
Okay.
It's measuring the years of, healthy life that are lost to being sick. It's the time you spend unable to function at your best.
So it's not just about mortality. It's really about the quality of life, the years you're living, but not really living.
Exactly. It represents a massive burden. People living years, sometimes decades of their lives in poor health, maybe tethered to dialysis machines, suffering from extreme fatigue, unable to work or, play with their kids.
Just this crushing weight.
It is a crushing weight, both on the individual suffering and on the healthcare systems that are trying to keep them alive.
So the why for our deep dive today is, it's pretty urgent. This isn't just some medical lecture for doctors.
No.
This is a public health puzzle. The source material paints this picture of a condition that is it's largely unrecognized. It's like an iceberg. You just don't see it until you crash right into it.
That is the perfect analogy for it. It's an iceberg. CKD is often called a silent epidemic precisely because the kidneys are so incredibly resilient. They suffer in silence.
You don't get any warning signs.
Not really. You don't get a cough, you don't get a rash, you don't get a fever. You often feel completely, totally normal until it is far, far too late.
And that silence, that's what leads to this premature mortality and creates this just crushing economic weight because, as the text points out, dialysis and transplants are incredibly expensive interventions.
They are, among the most expensive in all of medicine. And the tragedy, and this is really the core of what we are going to discuss today, is that we actually have the tools to detect it early.
Right.
We have the maps to steer the ship around the iceberg, but we so often miss the window to even use them.
Well, today we are going to look at those maps. We're going to unpack the clinical management of chronic kidney disease source text. We're going to move from these, frankly, scary statistics to the fascinating, intricate mechanisms of how the kidney actually fails. And then
we get to the good news.
And there is good news. There's huge news, actually. We're going to talk about some truly revolutionary treatments, some really surprising game changers that are literally buying patients decades of life.
Yeah, it's a very hopeful story in the end.
It is. But before we get to the solution, we have to define the beast.
Yeah.
What exactly is CKD?
So the definition is actually quite specific, and it really relies on the concept of time. CKD is defined as abnormalities in kidney structure or function that are present for 3 months or longer.
Okay, why 3 months? Why that specific time frame?
It's to distinguish it from an acute injury. So, for example, if you get really dehydrated running a marathon or you have a severe infection, your kidneys might take a hit for a few days. That's an acute kidney injury.
It's temporary.
It's temporary, and it often resolves. But CKD is a chronic, sustained state of damage. It's not just a bad week. It's a permanent shift in how the organ works. The damage is there, and it's not going away.
And in the source text, there are these two main acronyms that just keep popping up over and over. If we're going to understand this disease, we have to understand these two numbers. They seem to be the dashboard for the whole system, GFR and ACR.
Right. Think of these as the speedometer and the check engine light for your car.
Okay, I like that.
First, you have the GFR, or glomerular filtration rate. This is essentially the speedometer for your kidney function. It measures how well your kidneys are filtering waste from your blood.
So a high number is good, a low number is bad.
Generally, yes. It's measured in milliliters per minute. So a GFR of 90 or above is considered normal, healthy function. That means your kidneys are filtering, 90 milliliters of blood every single minute, cleaning it out perfectly.
And as that number drops, that's when you move through the stages of kidney disease that people hear about.
Exactly. A GFR below 60 is where we start officially seeing a disease classification, that's stage G3. At that point, you've lost about a third of your kidney function.
And you still might not feel anything.
You almost certainly feel nothing. Then below 30 is stage G4, which is severe. And then below 15...
That's the red line on the speedometer.
That's the red line. That's stage G5, end-stage kidney failure. That usually means the factory has pretty much shut down and you're going to need dialysis or a transplant to survive.
Okay, so GFR is how fast the factory's working. What about ACR? The text seemed to imply this one is just as important, maybe even more so, for catching it early.
Oh, it is absolutely critical. ACR stands for albumin to creatinine ratio. If GFR is the speed of the filter, ACR tells us how leaky the filter is.
Leaky. That doesn't sound good at all.
It's not. It's very bad. Your kidneys are supposed to act like a smart sieve, a very fine colander. They are designed to keep the good stuff in your blood, like red blood cells and valuable proteins, and let the bad stuff, the toxins and waste, go out into the urine.
Right.
Albumin is a specific, very important type of protein. It's valuable to the body. It should never be in the urine in any significant amount.
So if you have a high ACR, it means albumin is leaking out, the sieve is broken.
Yes. It means the barrier is damaged. It's like a coffee filter with a tiny hole in it. You're
Right.
getting coffee grounds in your cup. If you have albumin in your urine, what we call albuminuria, it is a definitive sign of structural damage to the kidneys filter.
So for this whole deep dive, we're really watching these two indicators.
Yeah.
The speed of the filter, which is GFR, and the leakiness of the filter, the ACR.
Precisely. And here's the really important part. You can have a normal GFR, a normal speed, but if your ACR is high, if you're leaking protein, you have kidney disease, you're in danger.
That is a crucial distinction. Okay, so let's jump into part one then, the physiology of failure. How does this damage actually happen? Because the text describes what it calls a vicious cycle. It seems like once the damage starts, it just feeds on itself.
It does. It absolutely does. And to understand this, you have to realize that each kidney is made up of about 1 million tiny filtering units called nephrons.
1 million in each one.
1 million in each one. Think of them as 1 million tiny workers on a factory floor. The pathophysiology, the mechanism of the damage, usually starts with an initiation risk factor.
That would be something like diabetes or high blood pressure.
Exactly. Those are the big two. These conditions come in and they essentially kill off some of the workers. Let's say diabetes damages the delicate blood vessels and you lose 200,000 of your nephrons.
So now you have 800,000 workers left.
Right. But here's the problem. The body still has the same amount of waste to clean. The workload hasn't gone down one bit. So what do you think happens to the remaining 800,000 workers?
Well, they have to work harder. They have to pick up the slack.
They have to work much harder. And this is where the compensation trap kicks in. The remaining healthy nephrons undergo a process called adaptive hyperfiltration.
Hyperfiltration, so filtering too much.
Or too fast. They literally dilate their input vessels, the arteries bringing blood in, to let more blood flow into the filter. They increase the pressure inside themselves to process more waste at a higher speed.
So at first, your kidney function, your GFR, it looks okay on a lab test because the survivors are just overcompensating.
Yes. It's an incredible adaptive mechanism. It keeps you alive. It's the body's way of saying, don't worry, I've got this. If you measured the GFR at this early stage, it might even be higher than normal because those remaining nephrons are just working so incredibly fast.
I'm guessing this isn't sustainable in the long run.
No. Think about those factory workers. If you ask them to work double shifts at high speed for a week, maybe they're fine, they get it done. But what if they have to do it for 5 years? For 10 years?
They're going to burn out.
Yeah.
They'll collapse.
They collapse. And that is precisely what happens to the nephrons. This state of intraglomerular hypertension, that's the technical term for high pressure inside the filter, causes the cells to get larger, a process called hypertrophy. But eventually, that high physical pressure physically destroys the intricate structure of the filter. It causes scarring or sclerosis, and so you lose more nephrons.
Which means the remaining ones, and now there are even fewer of them, have to work even harder.
And the cycle just accelerates. That is the vicious cycle of CKD. It's a snowball effect rolling down a hill, getting bigger and faster as it goes.
Now, the text singles out a specific villain in this whole process.
Yeah.
A molecule called angiotensin II. I feel like we need to put a face on this bad guy. What is its role in creating this high-pressure situation?
Angiotensin II is it's a hormone that your body uses to regulate blood pressure. It's essential for life. But in the context of a struggling kidney, it acts like a clamp. A clamp. To understand this, you have to picture the blood flow in a nephron. It has an input pipe, which is called the efferent arteriole, and an exit pipe, the efferent arteriole.
Okay, so blood comes in the afferent, gets filtered, and leads through the efferent.
You got it. Angiotensin II specifically constricts the exit pipe.
So it's squeezing the efferent arteriole.
Right. So imagine you have a garden hose with water flowing through it, and there's a sprinkler head in the middle. That's your filter. If you put your thumb over the end of the hose, blocking the exit, what happens to the pressure inside the hose back at the sprinkler?
It builds way up. The water backs up and sprays out harder.
Exactly. The pressure just skyrockets. Angiotensin II is the thumb on the hose. It turns up the pressure inside the filter. Now, in the short term, this forces more fluid through, which helps maintain your filtration rate briefly, but that sustained high pressure blows out the delicate membrane.
It damages the barrier.
And that allows albumin protein to leak through.
And this brings us to one of the most interesting and I think counterintuitive points in the source material. I always thought protein in the urine proteinuria was just a symptom. You know, like, oh, look, there's protein, that means the kidney is damaged. But the text says it's much more than that.
This is a critical distinction that really changes how we approach treating the disease. Proteinuria is not just a marker of damage, it is an active cause of further damage.
So the leak itself is rotting the pipes. Is that a fair way to put it?
That's a pretty vivid way to put it, but yes, essentially. Albumin and other proteins are actually toxic to the tubular cells of the kidney. That's the plumbing downstream from the filter.
Okay.
When these cells, which are not designed to see large amounts of protein, are suddenly exposed to high levels of it, they get irritated, they get inflamed, they release these inflammatory chemicals called cytokines.
So it actually causes inflammation inside the kidney.
Inflammation and eventually fibrosis, which is scarring. It scars the kidney from the inside out. So stopping the leak isn't just about cleaning up the urine test result. It's about stopping a toxic exposure that is actively killing the remaining healthy kidney tissue.
That really changes how you look at the treatments we're going to talk about later. We aren't just trying to lower a number on a lab sheet. We are trying to stop a toxic spill inside the organ.
Exactly. If we can stop the protein from leaking, we can stop the inflammation, and we can save the kidney for much, much longer.
Okay, so we've got the mechanism down. Pressure, burnout, leakage, toxicity. Now let's talk about the suspects. Who is causing this in the first place? Part 2 of our outline focuses on the leading causes.
In first world countries, the lineup is, it's pretty consistent and pretty grim. Suspect number 1 by a landslide is diabetes.
The source says it accounts for anywhere from 25% to 50% of all patients on dialysis. That is just a huge chunk of the problem.
It's the dominant driver. High blood sugar is incredibly corrosive over time. It damages the endothelial lining, the delicate inner layer of blood vessels all over the body, and the kidneys are just packed with tiny blood vessels, so they take a massive hit.
And suspect number 2?
Hypertension. High blood pressure. It's a vicious two-way street. Kidney disease can cause high blood pressure because the kidneys are what regulate your fluid volume and blood pressure hormones.
Oh, right.
And at the same time, high blood pressure causes kidney disease by just constantly slamming that high pressure flow into those delicate filters, wearing them out over years.
But there's a third one that I think doesn't get enough headlines. Obesity.
Yes. And the source is very, very clear on this. Obesity is a direct, independent risk factor. A BMI greater than 25 is associated with a threefold increase in CKD risk.
And that's independent of diabetes and hypertension, right? It's not just, oh, obesity leads to diabetes, which then leads to kidney failure. It's a direct line.
That's correct. Obesity itself creates that hyperfiltration state we were just talking about. Just think about the physics of it. A larger body mass has a higher metabolic demand.
More cells, more waste.
More cells, more waste. You have more blood volume to circulate, more cellular waste products to clear. The kidneys of a person with obesity have to work harder. They have to hyperfilter just to meet the demands of that larger body mass.
So even without the damage from high sugar, just the sheer physical demand on the kidneys causes that same burnout cycle.
Exactly. It's like running a car engine at red line all the time. Eventually, it just strains the engine to the breaking point.
Now, we call this the silent epidemic in the intro. We use that iceberg analogy. Why is it so silent? Why don't we feel the engine straining?
It's because the kidney has that massive reserve capacity we talked about. Remember, you have about 1 million nephrons in each kidney? You can lose half of them, literally 50% of your function, and the remaining ones will work hard enough that you feel completely normal.
That's terrifying.
It is. Patients are often asymptomatic until stage G4 or even stage G5.
So you could be walking around with stage 3 kidney disease, having lost half your kidney function, and have absolutely no idea.
Completely oblivious. By the time you actually feel sick, nausea, weakness, maybe some confusion, you have lost a huge amount of kidney function, and often that loss is irreversible.
So when the signs finally do appear, what are we looking for? The text mentions foaming urine, which sounds odd.
Yeah, and we need to be specific here because everyone sees bubbles in the toilet sometimes,
Well,
just depending on the speed of the stream.
Yep.
But this foam is different. It's caused by the protein changing the surface tension of the urine. It essentially acts like soap.
Like putting dish soap in the water.
Exactly like that. If you see persistent foam bubbles that kind of stack up and don't go away right after you flush, that's a major red flag for albuminuria.
What are some other signs?
Other signs are edema, swelling, usually in the legs and ankles, or even around the eyes, because your body isn't getting rid of fluid properly. And then there's this deep, profound fatigue, which is largely from anemia.
Anemia. That's a blood issue, isn't it? How does the kidney cause that?
It is a blood issue, but the kidneys are responsible for it. They produce a crucial hormone called erythropoietin.
EPO. I've heard of that in sports scoping.
That's the one. It's the hormone that tells your bone marrow to make red blood cells. When your kidneys fail, your EPO levels plummet and you become anemic. You just don't have enough red blood cells to carry oxygen.
So you feel exhausted all the time.
Completely wiped out. You also see things in the blood work like metabolic acidosis, where acid builds up in the blood or electrolyte imbalances, especially high potassium and high phosphorus.
I want to touch on this section about the inequality of CKD that the source brings up. This is a really complex and important part of the puzzle. It mentions some pretty stark racial disparities.
It does. The data shows a significantly higher risk of progression, meaning the disease gets worse, faster, in people of African, Hispanic, and Asian descent when compared to Caucasians.
Why is that?
It's a mix of things. Part of it is biological. We know about certain genetic risk variants like the APOL1 gene in people of African ancestry that strongly predispose them to kidney disease, but it is also significantly social and environmental.
But then there's this paradox that the text mentions. The Hispanic-Asian paradox.
It's fascinating, and the source explicitly calls it a key gap in the literature. Despite having higher progression rates and more comorbidities like diabetes and cardiovascular disease, patients of Asian and Hispanic descent actually have a lower risk of mortality than Caucasians once they reach end-stage disease.
That's bizarre.
It is. They live longer on dialysis.
So they get sicker faster but live longer once they're at the final stage.
Yeah.
That seems completely backward.
Exactly. We don't fully understand why yet. It could be some unknown genetic protection factors we haven't identified, or perhaps it's related to strong social support structures in these communities that help with the intense demands of care, or even dietary differences. But it highlights that this disease just doesn't look the same in everyone.
And we can't talk about inequality without talking about poverty.
No, we absolutely can't. The social determinants of health play a massive, massive role here. Low income and low levels of education correlate very strongly with higher rates of CKD.
The source lists some specific mechanisms here that are really depressing but so important to understand. It brings up food deserts.
Right, and this is a huge driver. If you live in an area where you can't buy fresh food, where your only option is a convenience store or a fast food chain, then you are, by necessity, eating processed food.
And processed food is?
Processed food is essentially a salt and sugar delivery vehicle. It is loaded with sodium, which drives hypertension, and sugar, which drives diabetes. You're basically consuming a diet that is designed to destroy kidneys.
And it even goes back as far as birth weight.
Yes, this is a really crucial insight. Poverty is linked to lower birth weight, often due to maternal health issues and poor nutrition. And here is the kicker. Babies with low birth weight are often born with smaller kidneys that have fewer nephrons to start with.
So they're born with a smaller factory.
They are born with a smaller factory. They have less of that reserve capacity before they hit the burnout point. They are starting the race of life with a significant disadvantage for their kidneys.
And then you pile on other factors.
Exactly. Then you add in higher exposure to nephrotoxins like lead from old paint or pipes or arsenic from contaminated water, which are all more common in lower-income housing or industrial areas. It's a perfect storm of susceptibility and exposure.
Okay, let's pivot. Let's pivot to solutions. We've set the stage, we know the villains, we know the silent nature of the threat. How have we been fighting this? Let's talk about what the text calls the old guard of treatment.
For decades, really, the cornerstone of therapy has been two classes of drugs, AC inhibitors and ARBs.
ACEIs and ARBs.
Right. ACEIs are angiotensin-converting enzyme inhibitors, and ARBs are angiotensin receptor blockers. You'll recognize these names. Lisinopril, ramipril, losartan, valsartan. If you have high blood pressure, you almost certainly know someone taking one of these.
And these are the first line of defense if you have that protein leak, that albuminuria, right?
Correct. The source states that if a patient has albuminuria, specifically what's called category A2 or greater, these are the absolute go-to first-line medications.
And how do they work? Let's go back to our garden hose analogy.
Perfect. So remember angiotensin II, the villain. The thumb on the garden hose that's jacking up the pressure.
Right, the bad guy.
These drugs remove the thumb. ACE inhibitors block the production of angiotensin II, and ARBs block its effects. The end result is the same. They dilate that exit pipe, the efferent arteriole.
So the pressure inside the filter drops.
The pressure drops way down, and when the pressure drops, the filter stops stretching, the holes don't get bigger, and the leaking of protein stops, or at least it slows down very significantly. It protects the physical structure of the nephron.
But there's a catch, isn't there? The body is smart. It tries to fight back. The text talks about something called aldosterone escape.
This is the constant frustration of treating biological systems. You block one pathway, and the body says, hey, wait a minute, my pressure is down, I need to fix this. It finds a detour. Over time, in some patients, the body bypasses the blockade and levels of aldosterone, another hormone that makes you retain salt and water, can start to creep back up. This can lead to fluid retention and the damage starting all over again.
So naturally, scientists thought, hey, if one drug is good, then two must be better. Why not combine an ACE inhibitor and an ARB? Block the enzyme AND, the receptor. Just block everything.
It was a very logical hypothesis. We call that dual blockade. The idea was to completely shut down the entire system so there could be absolutely no escape.
And the result of that brilliant idea.
It was worse than a failure. It was dangerous. The source is incredibly explicit about this. Evidence level 1B says do not combine them, period.
It actually caused harm.
It did. The big clinical trials showed that this combination caused a much higher risk of hyperkalemia, that's dangerously high potassium levels that can cause your heart to stop, and acute kidney injury, or AKI.
So it shut the kidneys down too much.
Exactly. It dropped the pressure inside the filter so low that the kidneys stopped filtering entirely. There was no added benefit to progression, only added harm.
So more is not always better.
Definitely not in this case.
Yeah.
That's a lesson we learned the hard way.
There are also some very practical management rules in the text for these drugs. The sick day rule. I feel like this is something everyone taking blood pressure meds needs to know, but I've never heard it mentioned in a standard checkup.
Oh, this is so crucial. ACEIs and ARBs work by lowering pressure, but they rely on you having a steady blood flow. If you get sick, if you're vomiting, have diarrhea, a high fever, and you get dehydrated, your blood volume drops naturally.
Right, and if you're taking a drug that is already artificially lowering the pressure in your kidney,
and you combine that with a low blood volume from dehydration, the pressure can drop to basically zero. The kidney stops filtering. You can go into acute kidney failure. You can end up in the hospital just because you took your regular blood pressure pill while you had the stomach flu.
So what's the advice?
The advice is simple. If you're sick and you can't keep fluids down, hold the meds. Skip the dose for a day or two until you are rehydrated again. It saves kidneys. It's a simple rule, but it prevents a tremendous amount of damage.
And a quick warning on pregnancy.
Yes, this is a big one. These drugs are teratogenic, especially in the second and third trimesters. They impair the development of the fetus's kidneys.
So they have to be stopped.
They absolutely must be stopped if pregnancy is planned or occurs. It essentially shuts down the baby's kidneys while they are trying to form.
Okay, so that's the old guard. They're reliable, they're effective, but they have their limits and they have their risks. Now let's get to the part of the deep dive that really blew my mind. The new superstars.
The SGLT2 inhibitors.
Sodium glucose transport 2 inhibitors. Now, these weren't even designed for kidney disease originally, right? This is kind of an accidental hero story.
It is. It's one of the great stories in modern medicine. They were developed as diabetes drugs. They were designed to help diabetics lower their blood sugar. The mechanism is actually pretty simple. They block the reabsorption of sugar in the kidney, so you just pee the extra sugar out.
So they were testing them for diabetes, looking for cardiovascular safety, and what did they find?
They started noticing in these massive clinical trials that the patients on these drugs, like in the big trials, Credence and DAPA-CKD, they weren't just controlling their sugar better. Their kidneys were staying healthy. Their GFR wasn't dropping like it was in the patients on placebo.
The text calls them a game changer.
That is not an exaggeration. We are talking about clinical trials that were stopped early, literally halted by the independent ethics boards, because the results were so overwhelmingly good, it was considered unethical to keep the other group on the placebo.
We'll talk about the specific statistic that the source cites, the real aha moment.
The calculation, based on the trial data, showed that for a typical patient in the Credence trial, someone around 63 years old who already had reduced kidney function using SGLT2 inhibitors could result in a gain of 15.1 years of kidney function before reaching failure when compared to standard care.
15.1 years.
Just think about that for a moment.
That's not an incremental improvement. That's a lifetime. That's seeing a grandchild born and then watching them start high school. That's the difference between retiring on dialysis hooked to a machine 3 days a week and retiring on a cruise ship.
It is monumental. In the world of chronic disease, we usually fight for a few months of delayed progression. We celebrate a year. Getting 15 years is unheard of. It completely changes the entire trajectory of a patient's life.
So how? How do they do it? If it's just about peeing out sugar, why does that save the kidney structure so dramatically?
It goes back to the mechanism of pressure, but in a totally different way than the ACE inhibitors. It's really elegant. SGLT2 inhibitors block the reabsorption of both glucose and sodium in the kidney tubules. And by doing this, they trick the kidney.
They trick it how?
So there's a sensor deep in the kidney called the macula densa. Its job is to taste the salt in the urine passing by. In a diabetic kidney, that sensor gets confused and tells the input pipe, the efferent arteriole, to open up wide, which causes that damaging hyperfiltration.
Okay.
But when you take an SGLT2 inhibitor, you block salt from being reabsorbed, so more salt flows past the sensor. The sensor tastes all that extra salt and thinks, whoa, there's plenty of salt here. The pressure must be too high. We don't need to work so hard. So it sends a signal to constrict the input pipe.
Wait, so the ACE inhibitors open the exit pipe?
And the SGLT2 inhibitors slightly close the inlet pipe.
That's a perfect 1-2 punch on the pressure.
It's exactly that. Both achieve the same goal. Lowering that damaging internal pressure of the filter, they stop the hyperfiltration, they let the kidney rest. It shifts the kidney from a state of redlining to a state of just cruising.
That is incredible physiological engineering. So who should be on these now?
The recommendations have shifted incredibly rapidly because the evidence is just so strong. They should be considered for pretty much all patients with type 2 diabetes and CKD, specifically those with albuminuria. And increasingly, evidence like the DAPA-CKD trial suggests they help even in non-diabetic kidney disease.
Wait a minute. So even if I don't have diabetes, this diabetes drug can save my kidneys?
Yes, because the primary mechanism of protection lowering the pressure in the filter works, regardless of whether high sugar caused the initial damage or if it was something else, like high blood pressure.
But as with everything in medicine, there are always risks. What's the downside? What are the side effects?
There are a few very specific side effects to watch for. One of the more serious, though rare, is something called euglycemic DKA.
Okay, DKA is diabetic ketoacidosis, right? That's a true medical emergency. It usually happens when blood sugar is sky high.
Exactly. But the key word here is euglycemic, which means normal sugar. Because these drugs are making you pee out all your extra sugar, your blood sugar might read as normal on your fingerstick meter.
Ah, I see the problem.
But your cells might be starving for fuel, so the body starts breaking down fat for energy and producing acid, or ketones. You get all the danger of DKA without the warning sign of high blood sugar.
That's really tricky because a doctor in the ER might check the sugar, see that it's normal, and completely miss the acidosis.
Correct. So patients need to be educated on the symptoms. Nausea, vomiting, abdominal pain, shortness of breath. And they need to know to mention they're on an SGLT2 inhibitor. It's rare, maybe 1 in 1,000 patients, but it's serious.
And then there are infections.
Right. This is the more common one. You are putting sugar in the urine. Bacteria and yeast absolutely love sugar. So genital mycotic infections, yeast infections, are fairly common. About 1 in 3 patients might experience one.
Is that manageable?
Usually, yes. With over-the-counter antifungal creams, you very rarely have to stop the drug because of it. But there is one other rare but very severe infection mentioned in the source: Fournier's gangrene.
The name alone sounds terrifying.
It is. It is a necrotizing infection of the perineum. Basically, it's a flesh-eating bacteria attacking the genital area. It is a true surgical emergency requiring urgent surgery and heavy-duty antibiotics.
And that's linked to these drugs.
It's extremely rare, but there's a warning for it, so patients need to know to seek help immediately if they have significant pain, tenderness, redness, or swelling in that area.
So despite these risks, the common yeast infections, the rare DKA, the extremely rare Fournier's, the consensus seems to be that the benefit 15 years of life heavily outweighs them for most people.
Absolutely. The risk reduction for needing dialysis or dying is so profound that for the vast majority of appropriate patients, it's not even a close call.
Let's move to part 5 of our dive, the supporting cast. So we have the old guard, the ACEs and ARBs. We have the new superstars, the SGLT2s. But there are other players on the field. Tell me about this drug, finerenone.
Finerenone is a newer player. It's a nonsteroidal mineralocorticoid receptor antagonist, or MRA.
That is a mouthful. What does it actually do?
So remember that aldosterone escape we talked about, where the body fights back against the ACE inhibitors and causes inflammation and scarring?
Right, the detour pathway.
This drug blocks that detour pathway. It specifically targets the receptor for aldosterone, reducing that inflammation and fibrosis.
How is it different from older drugs that did something similar?
Older drugs like spironolactone did this too, but they had a lot of hormonal side effects, like gynecomastia or breast development in men because they were steroidal in structure. Finerenone is more selective, it's non-steroidal, so it blocks the bad stuff, the inflammation and fibrosis, without as much of the hormonal baggage.
And the text mentions the Fidelio DKD trial.
Yes. That was the big trial that showed Finerenone reduces both bad kidney outcomes and bad cardiovascular outcomes. It's a great niche drug for patients who maybe can't tolerate SGLT2 inhibitors, or perhaps as an add-on therapy in certain cases. The main risk you have to watch for is hyperkalemia, high potassium, so you need to monitor blood tests pretty closely.
Now let's talk about a bit of a controversy. Blood pressure targets. The SPRINT trial. This feels like a Goldilocks problem. What is the just right blood pressure? Not too high, not too low.
This has been debated in medicine for years. The SPRINT trial was a massive landmark study that really tried to answer this. It took a large group of high-risk patients and tested a standard target keeping their systolic blood pressure below 140 versus an intensive target, which was keeping it below 120.
And the winner was?
The winner was intensive. Getting the blood pressure below 120 reduced death from all causes and cardiovascular events significantly.
So lower is better, case closed.
Yes, BUUAT. There is a very important trade-off. The intensive group also had significantly more side effects, things like hypotension or low blood pressure, syncope, which is fainting, and electrolyte issues.
Right, because if you drop the pressure too low, grandma falls down.
Yeah.
And a broken hip in an elderly patient can be a major life-threatening event in itself.
Exactly. So the verdict from the source material is nuanced. It's not as simple as everyone to 120. It says a target of less than 120 is appropriate, but it requires shared decision-making.
What does that mean in practice?
It means you have to have a conversation. You need a reliable patient who can monitor their own blood pressure, who isn't a high-fall risk, and who understands the potential side effects. It's not a one-size-fits-all rule. You have to treat the patient sitting in front of you, not just the number on the chart.
And of course, we can't forget lifestyle. I know. Every doctor says eat better, exercise more.
Yeah.
But what specifically matters for kidneys?
For kidneys, number one with a bullet is sodium. A low-sodium diet is non-negotiable. We're talking less than 2 grams a day.
Why is sodium so uniquely bad for the kidneys?
Sodium makes your body hold on to water, which directly raises your blood pressure. But it also directly interferes with the effectiveness of the medications. If you are taking an ACE inhibitor but eating a high-salt diet, you are basically blunting the effect of the very drug that's trying to save your kidney. You are fighting the cure with your fork.
And what about protein?
This is a really interesting one. The source specifically warns against nutritional protein supplements. In the modern gym culture, everyone is chugging huge protein shakes.
Right.
But for a failing kidney, that massive, sudden protein load is like throwing gasoline on a fire. It dramatically increases the filtration load and drives that damaging hyperfiltration we talked about.
So maybe consult a dietitian before you buy the mega jug of whey protein from the health food store.
Please do. And then there's weight loss. Real sustained weight loss can actually stabilize GFR and reduce that protein leak. It's simple physics again. You reduce the workload on the factory. If you lose weight, you reduce the metabolic demand, and the kidneys don't have to work so hard. And of course, stop smoking. It raises heart rate, raises blood pressure, and damages blood vessels. It just makes everything worse.
Finally, part 6 of our dive, the team approach. This is clearly not a solo sport.
Not even close. The complexity we've just discussed, managing SGLT2 side effects, monitoring potassium with MRAs, adjusting blood pressure meds, teaching the sick day rules, counseling on a low-sodium diet, it's far too much for one 15-minute visit with a primary care doctor.
The source lists a whole dream team: a nephrologist, a specialist pharmacist, a nurse educator, a dietitian, and a social worker.
And here's the economic argument from the source that I just loved. It really puts it in perspective. It notes that the salary costs of this entire multidisciplinary team could be recovered in 1 year if they managed to delay the start of dialysis by just 1 year in only 2% of their patients.
Wow, 2%. That's all it takes for it to pay for itself.
That's the incredible return on investment of preventative care right there. Dialysis costs the healthcare system tens, even hundreds of thousands of dollars a year per patient. Paying a dietitian to help someone save their kidney is just pennies on the dollar in comparison. It makes pure economic sense, completely aside from the moral imperative to do it.
And one last practical bit from that team section: vaccines.
Crucial. CKD patients are vulnerable. Their immune systems just aren't as strong. The annual influenza shot, the pneumococcal vaccine, and the hepatitis B series are all strongly recommended.
Why hepatitis B specifically?
Hepatitis B is especially important because if you do, unfortunately, end up on dialysis, the risk of blood-borne transmission goes up significantly. You want to be protected well beforehand.
So we've been on quite a journey today. It's a lot.
We have. It's a lot to take in, for sure.
We started with this silent epidemic. 697 million people, nearly 10% of the world, walking around with these ticking clocks inside their kidneys. We went down into the microscopic level of the nephron, watching it hyperfilter and burn itself out. We saw the damage caused by that villain, angiotensin II, and the toxic nature of those protein leaks.
And then we looked at the tools we have to fight back, the old guard, the ACE inhibitors that open the exit pipes, and then the revolutionary SGLT2 inhibitors that tap the brakes on the input pipes and can buy us an incredible 15 years. And, of course, the lifestyle changes that stabilize the whole system.
It really feels like we are at a turning point in the history of this disease.
I absolutely think we are. For a very long time, a diagnosis of progressive CKD was a slow, sad, inevitable march toward dialysis. Now we have breaks. We have legitimate, powerful breaks to stop that progression in its tracks for many people.
Which brings me to our final provocative thought for today. The source gave us that incredible 15-year statistic for the SGLT2 inhibitors. So, if we have the tools to delay dialysis by over a decade, why is CKD still killing 1.2 million people a year?
That is the tragedy, isn't it? It's the gap between clinical knowledge and public health implementation. We have the drugs, we know the mechanisms, but are patients getting diagnosed early enough when their GFR is still good?
Right.
Are they getting access to these newer, more expensive SGLT2 inhibitors? Are they being educated on the diet, on the sick day rules?
It sounds like the science has moved faster than the healthcare system can keep up.
It has, in many ways. The next great frontier in medicine isn't just discovering a new molecule in a lab. It's figuring out how to get the incredible molecules we already have to the 697 million people who need them. It's about access, it's about education, and it's about breaking the silence.
So for you listening, the takeaway today is crystal clear. Know your numbers. Ask your doctor about your eGFR and your UACR. Don't let it be a silent disease for you. If you catch the leak early, you can fix the pipes.
Absolutely. Knowledge is kidney protection.
Thanks for diving deep with us today. We'll see you on the next one.